kickoff. As you know, over the last several years, the mayor has made a number of significant improvements in our EMS service. And today we're here to kick off one of the more significant ones. Let me begin by introducing some of the people who are here with us. First of all, we have, representing the Southeast Michigan Hospital Council, Steve Walters. We also have, representing the Wayne County Medical Society, Dr. Krishna Sawhney. Representing the Detroit Fire Department, Commissioner's Office is Phil Gorak. I'm James Webster from the Mayor's Office. John King, the Director of EMS. Jeff Keaton, who is the President of the EMS Technicians Union. And we also have two of the principals from Young and Rubicam who were essential in putting together the public awareness campaign. Phyllis, Hurks, who was the producer, and Tyus, who was the art director. As you can tell from your press release, there are a number of improvements, as I said, that have been made. We've almost cut response time in half. Our communication and interaction with the hospital have improved dramatically. We have a new CAD, computer-aided dispatch, and ADL system, which helps in dispatching our EMS units. Mr. King is using a management tool, which we refer to as exception reporting. And with all of these resources, in addition to this public awareness campaign, we're hoping that Detroit will be the leading city in EMS service. The PSAs, as you all know, focus on the thing only when a life is on the line. This is an appropriate thing because of the various kinds of unnecessary and nuisance types of calls that we receive. And Mr. King will elaborate further on the number of these calls and the impact of it, but when you get a chance to see the videotape, which is set up in the other room, I think it will impress you because one of the things that it focuses on is just the severity of the impact of those nuisance calls. And as you know, each time an EMS unit responds to a call, it's out of service. And so the crucial issue is when there's not a necessary call. Your life or my life may be on the line. We have about 300 brochures which are available. There's going to be a mass mailing of these brochures to various city hospitals, our own public health facilities, HMOs, and other city facilities. We're hoping that through the combination of this campaign that we will be able to deter the number of nuisance calls or unnecessary calls that EMS receives. I want to thank you on behalf of the mayor for your role in this public awareness campaign. I can't think of a more important and crucial public awareness effort that impacts upon all of us and the quality of life in the city. So thank you for being here, and let me now introduce you to John King.
Thank you very much, James. It's important that you are here, and as journalists and working with the media, you're probably the most important component in getting out that message. Before I'll make just a couple of comments and I'll turn it over to some questions if you want to. Number one of the organizations that contributed to this was Young and Rubicam, and they did a yeoman-like task in getting this together. And also Michigan Bell, who without Michigan Bell, we could not even respond to it. And it's important that you and the media understand what Michigan Bell's role is when we're talking about emergency response. Without Michigan Bell, we couldn't get the calls in. You know, we have the ability that we didn't have some years back. The citizen can make a call on a payphone without the need of any coins at all. We also are able, when they make contact with our fire dispatch, 911, even if a person lapses into unconsciousness, we all automatically have the address from which they call. So Michigan Bell is an important component not only in getting this together, but in the overall scheme of things. And I'd be remiss if I didn't mention Wayne Medical Society, and also the Southwest Michigan Hospital Council. As you're well aware, hospitals throughout this country are decreasing almost on a daily basis. And during this decade, I see no reason for that trend to turn around. And yet in the last couple of years, we've been able to talk to the people in the hospital. There is nobody that is critically injured or in a life-threatening situation that we can't get into those hospitals. We don't know how long that will continue, but we know that when EMS started in 1972, we had 42 participating hospitals. That number has decreased by more than 46%. So it is important that we have the ability to get to the hospital with a patient that is in need, rather than taking one that is not considered a high priority. As far as how the public understands when they should call for EMS or not, a good rule of thumb is if that individual is ambulatory or walking, no difficulty in breathing, it happens to be a wrist injury of some kind or other, and they have transportation or can get transportation, we consider that a low priority. We see no reason in transporting an individual to the hospital at a cost of $125 to that citizen. They can catch a cab for $10. And this is something that the public should be made aware of. I mean, we're not out there, we are the emergency medical service. We're not, the E doesn't stand for entitlement. Nobody's entitled to ride in that vehicle unless they're an emergency. And I think that should be made clear to everybody. We're there for an emergency. We're not just a medical service. If we were, we transport everybody. As far as abuse and the people we're trying to hit, we're not trying to talk to those individuals that have a wanton disregard for life, who we believe are few. We're trying to talk to those individuals in the public that are given an improper use. So when I say abuse, I'm talking about an improper use, when maybe they should not have called. There are cases when we go to a home, that individual has a minor injury, and the citizen's husband or wife says, well, we'll follow you with our car. Well, if they can follow us in their car and he's ambulatory, they should have taken an individual. I think you don't have to be a medical giant to understand there are times to call and times not to call. And we're doing everything in our power, and have been doing, the city has been doing at least for the last 3 years that I know, to reduce the number of runs and to increase the response to those type of medical emergencies. I guess that's all I have to say without running on anymore, but that's important that everybody knows those things.
John, what percentage of your runs are false alarm or immediate runs?
Well, Jim, 45% of our runs, on average, that changes from month to month by 2 or 3%, but 45% of our runs result in a non-transport. And that's a significant problem, because we could have been somewhere else handling a patient that is in need. And it's important to me, Jim, because I've got father, mother, and relatives in this city, and I just don't want to be running around the city.
John, once your units get that call and it goes out to them, talk about the fact that, I mean, once it shows up in the truck and they have to go. I mean, whether it's a stub toe, I mean, they have to run like it's an emergency. Is that a fair assessment of the way the system works now? Isn't that part of the situation here? I mean, your guys are running full blast, whether it's a stub toe or a shoe. Is that a fair assessment?
No, that's quite accurate. You know, and we're dealing with that type of problem where we will be making sure that if it's a non-emergency call, it'll be treated like a non-emergency call. That doesn't mean that we won't respond. This week, one of the things that we've done, once my unit gets a call, they will respond. If it is a stub toe, for an example, and if there is a code 1 or a high emergency, a run of higher emergency, code 1 or code 2, they will abort that run and go to the highest one. And the next available unit will take that one we consider less of an emergency. That will be handled by our EMS dispatch. They will make that judgment.
Well, the computer folds into that as well in terms of deciding what...
Well, the computer is at the inception of the whole run. What I'm talking about, we have dispatchers downtown. They will see that we're going to a run that is not of a high priority.
Speaking of,
And then we will send it to one of a higher priority. And that's in the works now. But you're correct. We are looking at the whole system, and we're doing everything on our end. Hopefully, you'll assist us. And all we're asking for the public is cooperation on their end.
I guess my point is that previously, if you had that run show up in the truck, they had to go just as fast and just as quick to the sore throat or stub toe as they did the shooting once they got the call. Is that it?
They still do that.
Okay, Chief, well, maybe to make it simpler, will the units be responding code 1 to stub toes, people with high fevers?
As of now, we respond to all runs in the code 2 mode, code 1 mode.
And y'all use private ambulance services. How many of those do you use, and how do you determine when to use them? When do you use?
We have a contract with private ambulance company, and they give us 3 units every day, 7 days a week, 365 days a year. They work from 2 p.m. until 2 a.m. And that's the busiest part. Our busiest response time is approximately 4 p.m. to 12:30. So they take care of some of the overload that we have. They respond to all runs.
Are you concerned at all that this might have further the public's negative opinion of some of the emergency units in the city? Some of them believe that they're slow to respond, and if you go to a call that you don't consider serious, then you turn the people down.
Good question. All I can say is, I know there's a perception. The reason the perception is out there may be because I'm guilty of not letting the public know enough about what we do. You know, as Dr. Weathers said, anytime you decrease response time, about 40%, in less than 3 years, and bring you with not only within the average, but maybe a little bit above the average of what's done in other major cities, I think we've done a dynamite job, and I think it's up to me as the chief of EMS to get that message across, and hopefully I'm doing it a little bit better talking to them.
Let me add on to that, because I don't agree that the public has an overall negative perception of EMS. Obviously, there's some instances in which there is some dissatisfaction. But overall, I would think there's a great deal of not only affection, but appreciation for the kinds of services our EMS technicians provide.
Mr. Walters, has there been a decrease with hospitals closing during peak and busy hours? Has there been a decrease in that at all?
There have been a number of hospital closures and consolidations with mergers of hospitals. So the number of available emergency rooms in the county, I'm sure, and in the city has declined somewhat. However, we're finding that ambulance runs in particular, emergency calls and ambulance runs are up, not only in the city of Detroit, but in Russell Wayne County, in Oakland County, Macomb County. It's happening in most major metropolitan areas around the country as people start, as people, system becomes more and more strained, people are seeking primary care services in emergency departments, which leads to an overcrowding problem there, and people with real emergencies have a harder time getting into the system.
John, I have 2 questions for you. Can you clarify who will make, because this sounds like a change in addition to this campaign, that the dispatchers will now prioritize the runs differently? Is that a fair assessment of it? In other words, that the shooting will get a higher priority than the stub toe? Or if someone's running on a stub toe and the shooting comes in, the stub toe is going to have to wait and they're going to have to go. Is that a change from what you're doing?
Yes, it's internal. It's one within the fire department. I have told them that we go to the one with the highest priority.
And that has changed.
That's correct.
And secondly, how, if at all, will this decrease in non-emergency calls, if your campaign is successful, help in the apparent violence against some of the units, be they rocks or whatever, bullets, whatever? Will this help in that regard?
The only thing that I know that this change will help, it will get to the individual that has a life-threatening situation. Anything else, and that's my primary concern, and that's the only change that I know that will be significant.
Will it make it safer for the, not safer, but will it improve the situations for the medics who get there? Sometimes they're getting there later than we want them to get there because they've been running on non-emergency. The fact when somebody's running on a stubbed toe and somebody's waiting over here for a heart attack, you back up.
I'm just not sure.
We in medical profession hope that this awareness will bring to the attention of the people that using these ambulances in a proper fashion and utilizing this 911 line in a proper fashion helps us all. If we do not get a sick person to the hospital emergency room in proper time, we are doing a disservice to all of us, especially our patients and people living in Detroit. So this is our priority, that we request you start using the 911 line properly and EMS properly so we can get the sick people into the hospital so the physicians can provide proper care. Remember, in Detroit, we have probably one of the best trauma centers in this nation, which is serviced by one of the best physician group in this nation, but we got to get the patients in time as early as possible to provide them with the best possible care. And that's our request to you all, that 911 should be utilized when it is needed. And that should only be utilized when it is a life-threatening emergency.
Thank you. Is the change in the dispatching, which you put into effect, is that going to be done by the dispatcher, or is that done by the computer, or by both?
Dispatcher.
So the computer doesn't make that decision, or
Dispatcher makes the change.
is that a statement in favor or against I thought the computer was supposed to help you in that regard in terms of
Oh, the
prioritizing.
computer can help in a lot of ways. It's something that I'm doing initially right now, but certainly that's something that we can always program into the computer. Whether it has the capabilities or not, I'm just not a computer expert and I can't really tell you.
But you want that done now,
I just want it
in
done.
conjunction with this campaign.
We're trying to get to the people that really need our help. One way we can get to them is by having needless calls reduced. We're going to work on our end in a number of areas, and that's one of them.
You should also know that we've worked in conjunction with several medical experts in the area. Our own Dr. Bob, who is the EMS medical director, and there have been protocols developed that both the dispatchers, the 911 operators, and eventually it will all be programmed into our CAD computer system that will help in this priority kind of dispatching. So what John is referring to is the initial phase of that, but it will be backed up by a number of other kinds of resources, and it's something that we've had in the works for a couple of years now.
Does this change shift the role of the dispatcher, or force the dispatcher to get any more, if this is the right word, aggressive on the phone to find out if that is in fact a sore throat, or is it a shooting in terms of the, because that's where you're going to make your determination, right, based on the
Well, the determination
information
is made by the time it gets to EMS dispatch, they have no contact with the citizen. And it will come over as heart attack, difficulty in breathing. Under the comments, we know specifically what's wrong with that individual by the comments that are elicited from to 911. So
the 911 operator determines
but
that.
the change will be made here internally.
Is there training been offered in any way? I mean, you're asking them to make judgment calls now that would be pretty critical.
Training is ongoing, not only with EMS dispatchers, but 911 operators today are at my training facility, receiving training. There have been a number trained already, and we're ready to go full blast on the course of the
you're confident that you get a hysterical call, when the lady is moving or something.
In those type of cases, we would consider that a code 1 call. If we have a hysterical individual, if there's any doubt, Jim, in any way, we make it a code 1, and that's the way it's
John, maybe someone else can answer this too. Has this campaign or these kind of efforts been tried in other cities and to what success? It's hard. We certainly found that the first city that's had the abuse with the 911 system. If you know, similar campaigns had any effect in other cities in terms of knocking down?
I really can't answer that. I'm not sure if there's anybody here who can. I don't know if you doubt it. I really can't answer that. I don't.
The one thing that I know is that the Detroit campaign, Detroit Hope, is going to be the best that ever was. Now let's go and see the videotape, okay? Thank you.
You never know how you do it. You reflect back and they'll only have about 10 seconds. You don't really know how you do it.
Listen, pal, I got a pulled hamstring, and I'm supposed to play tomorrow.
Life-threatening? Sir, if that dog was going in your yard...
Yeah, it's an emergency. I've got to get to the hospital for a blood test.
Hello, you asked so many questions and already stopped bleeding.
When people call EMS for anything other than a life-threatening medical emergency, they threaten the lives of others. Don't use a good thing to death. EMS, only when a life is on the line.
It's 2. We got one more.
Well, I can't drive myself to the hospital with a sprained ankle.
You don't think a toothache at 3 a.m. is an emergency?
Danger? Yeah, I'm in danger of missing my blood test. Now, how about that ride?
Look, you come get me, and I'll answer all your questions.
When people call EMS for anything other than a life-threatening medical emergency, they threaten the lives of others. Don't use a good thing to death. EMS, only when a life is on the line.
See, that's when they were, it's almost like the